Hello, everyone. Welcome to the Preemie Chats. Preemie Chats is our weekly educational sessions for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I'm a Preemie parent and executive director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led organization that helps families in and out their ICU through support, education, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who wants to see our little babies thrive. And if you're watching live today, please bring your voice to this table. Leave comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching from. And today's topic is kidney health in preterm babies. Preterm babies are at a higher risk for kidney problems in the short and long term. This talk will cover why they are at increased risk and how to monitor for signs of kidney problems. And I have here joining us live, not from Vancouver, but from San Diego, at a conference. Actually, Dr. Blake Sandery is a pediatric nephrologist at British Columbia Children's Hospital. She has been caring for children with all kinds of kidney problems across all age groups for almost 10 years. Her expertise and research interests are in kidney outcomes in infants and children following critical illness, including prematurity, intensive care admission, and cancer diagnosis. She's passionate about educating healthcare providers and parents to ensure the best kidney outcomes possible for our future generations. Dr. Sandery, thank you so much for joining us here today in the middle of your conference. We are very grateful to have you here with us today.
Oh, no, you're very welcome. I'm really happy to be here. So thanks for the invitation.
And for all of you watching us live, please do ask your questions and make comments, and we're going to address them after Dr. Sandery's presentation. And the floor is yours.
Great. So good morning, good afternoon, or good evening, wherever you may be streaming from today. As Fabiana said, my name's Blake Sandery. I'm a pediatric nephrologist who lives in Vancouver, and I work at the British Columbia Children's Hospital and the University of British Columbia. And so today we're going to take a little bit of time to talk about kidney health in preterm babies. And apologies if there's any technical difficulties along the way. I'm kind of on my phone due to the Wi-Fi, so apologies if the camera's a little bit shaky. But we'll do our best and get through it today. So next slide. So I have no disclosures to talk about. Next slide. And today I wanted to stop for a moment and acknowledge that I am an uninvited guest living and playing and working on the ancestral and unceded lands of the Stolo, Tsleil-Waututh, Musqueam and Squamish nations, which is the city that is now known as Vancouver. But as Fabiana mentioned, today I come to you from the city known as San Diego, which is on the lands of the Kumeyaay people. And I would like to pay my respect to elders past, present and emerging, and acknowledge the vast-ranging negative impacts of colonialism on Indigenous people's health in the country that is now known as Canada. And this picture here is from one of my favourite places on these lands, which is up at Whistler, with some recent snowfall up there. And when you have a moment later on today, or perhaps on the weekend, I encourage you to go to this website, nativeland.ca. If you put in your postcode there, you can learn a little bit more about the native lands that you live and work on, and the people who live there as well. So what are we going to talk about today? We'll firstly talk about what the kidneys do, then how the kidneys develop. We'll talk about kidney injury in premature babies and how this may lead to chronic kidney disease. And we'll also go through some monitoring in childhood. Next slide. Firstly, kidney function and structure. So the kidney is responsible, next slide. So the kidney is responsible for a lot more than just making pee. Firstly, the thing that most people know about is toxin removal. So the kidneys clean your blood, but they also are responsible for fluid removal. And the next thing that they do is they're actually involved in blood pressure control. So via various hormones or by secreting more or excreting more water from the body. The next thing down on the left and the bottom, acid-base balance is something that the kidneys regulate. They also control the electrolyte balance in your body. So all the different salts like sodium and potassium, the kidneys are responsible for balancing those. And one of the other things the kidneys do is they secrete a hormone that actually signals red blood cell production. So your kidneys are really important and they do a lot. Next slide. So this is the kidney structure. So on the left, you can see a picture overall of a kidney. With on the red vessel is blood going in via the artery. So the unfiltered blood gets filtered in the kidney and then leaves via the blue blood vessel, which is the vein. And the tube going down, the kind of cream looking tube is a ureter, and that's where the urine drains out. On the right-hand side, you can see at the top there's this little red ball, and that's a little ball of blood vessels. So where the unfiltered blood goes in and the filtered blood goes out. That little structure there, that little filter is called a glomerulus. Then where that filtrate or stuff that comes out of the filter goes through this long tube, this long curly tube, and that is the, I guess, refining part of the filtering structure. So it makes lots of changes to the urine along the way. And that whole part there, that filter, the little red ball, the glomerulus, plus that long tube, that's called a nephron. And we actually have 1 million nephrons roughly in each kidney. Okay, next slide. So how do the kidneys grow and develop? Next slide. So before you're born is when the majority of your kidneys develop. So these little filters, those nephrons that I was talking about, that development occurs from the 6th week to the 36th week of gestation. And the 3rd trimester is the most active period of this filter development. So 60% of filters are actually formed in the 3rd trimester. And we know that preterm birth interrupts this process, and it results in you having a lower number of those kidney filters. So you can see here this graph down the bottom, and this was actually performed from an autopsy study of neonates that had unfortunately passed away from other reasons, and they looked at how many filters were in these kidneys. And you can see that at 15 to 20 weeks gestation, not many filters at all, less than 100,000. And then if you look into that extremely preterm birth bar, so that green bar, each kidney would have about 250 to 300,000 nephrons. And you can see in that last trimester, the 3rd trimester, the number of nephrons really increases dramatically, so that by the time you get to term, represented by that orange bar, you've got 800,000 to nearly 1 million nephrons in each kidney. Next slide. So there is a little bit of kidney development that occurs after babies are born, so extrauterine kidney development, but these filters might only develop for about up to 40 days after someone's born. Unfortunately, even if you do get new filter development, the filters that develop are often abnormal because they're small and they're in abnormal shape. We also know that the filters that develop after birth will age faster, so they're not going to last as long. And even if you do get some postnatal filter development, really preterm infants will still have a reduced filter number. And so if you look at these kind of graphics down the bottom, so on the left, imagine an infant that's born at 26 weeks gestation. They hopefully get an extra 40 days of filter development or nephron development, but that only puts them at 32 weeks gestation's worth of nephrons. So they're still missing out on 8 weeks development of these little filters, the nephrons. Next slide. So what controls this postnatal kidney development? Well, the mechanisms responsible for postnatal filter development are really unknown. It's thought that oxygen or high oxygen exposure might be bad because there was a study on rat pups that showed there was abnormal filter development when you had high oxygen exposure. But what we do know is that acute kidney injury, or AKI as it's called in the medical world, is bad because it inhibits postnatal filter development. Next slide. So let's talk for a little bit about kidney injury in preterm infants. Next slide. So acute kidney injury, or AKI, as it's called, what is it? It's an abrupt decrease in kidney function that usually is associated with some structural damage, but also loss of kidney function. Acute kidney injury is temporary and people often recover normal kidney function in the short term. But we do know that in the long term, if you have acute kidney injury, it can contribute to increased risk of future kidney problems. Next slide. We know that preterm babies are at high risk for acute kidney injury, and this is due to multiple mechanisms and multiple reasons. Firstly, there's a lot of exposure to medications that might harm the kidney. Preterm babies and newborn babies are at increased risk of infection, and we know that when you're sick with an infection, you're more likely to have injury to your kidney as a result. The kidneys are immature, so they're more susceptible to any injuries, and also infants with congenital heart disease are more at risk of getting kidney injury. Next slide. So I wanted to talk a little bit about a paper that was published back in 2017, and this was called the AWAKEN study. So this was a study that was conducted in 24 neonatal intensive care units across 4 countries, which were Canada, the United States, Australia, and India. And there was over 2,000 neonates that they looked at in this study. And they looked at how often they got kidney injury and what were the factors that were associated with kidney injury in these babies. And so I'll just draw your attention to the top right pie chart. So you can see here, this is the most premature infants. So those that are between 22 weeks to less than 29 weeks gestation at birth. And almost 50% of them in this dark orange here, 48% had acute kidney injury, which is huge. Almost half of these babies are getting an injury to their kidneys during their NICU stay. The slightly older infants, so down on the bottom right, the 29 to 36 weeks, they had a much lower rate of kidney injury, with only about 18% of them getting kidney injury. And then if you move around to the left, you can see that those that were born near term, greater than 36 weeks, they had about 37% of those infants having acute kidney injury. So you can see that it's really a large amount of the infants going through the nursery are getting an injury to their kidneys. And you might say, oh, that's interesting that the older, more term babies have more injury to their kidneys. But this is a little bit of a sicker population, because usually term babies that are admitted to the neonatal ICU have other medical problems that might contribute to having a kidney injury. They're often a bit sicker. So next slide, please. So they also looked at outcomes of these neonates and whether they had any worse outcomes than the neonates who didn't have acute kidney injury. And what they found in this study, that neonates with acute kidney injury had an increased risk of mortality and also a longer hospital stay. Next slide. So this again is from the AWAKEN study. They looked at stage of acute kidney injury and the likelihood of survival. So we'll just walk it through. So this top line here, the blue line, is if you didn't have acute kidney injury. And then the different stages of kidney injury, 1 to 3. So 1 is the mildest type of kidney injury, and 3, the one in purple, is the highest grade or most severe kidney injury. And then along the y-axis of the graph, you've got overall survival, and on the bottom, the x, you've got time. So you can see here the blue line, those infants who didn't have any acute kidney injury, their survival is up near 95%, so really high. But if you focus on the purple line, the infants who had stage 3, the most severe AKI, their survival is only about 75%, so much lower than those infants who had no acute kidney injury. Next slide. So now we'll talk about later on what happens to infants after they've left the neonatal intensive care. So we'll talk about potential chronic kidney disease in preterm and low birth weight children. Next slide. So what we know from adult studies is that being premature or born low birth weight is a risk factor for adverse kidney outcomes in adults. It's a well-established risk factor for high blood pressure. It's a risk factor for chronic kidney disease. And how early these conditions develop, though, has been really unclear up until recently. Next slide. So this was a study that was done in Sweden that was published by Crump and colleagues back in 2019. And this was a registry study. They looked at 4 million live births in Sweden. They found that only about 4,000 people had chronic kidney disease. But what they noticed was that if you see here on the left, with decreasing gestational age, so born less than 28 weeks, you had an increased risk of developing chronic kidney disease. So HR stands for hazard ratio, which is, I guess, your relative risk compared to what is the normal population. So the normal population here would be those born at full term. So those born less than 28 weeks had a 3 times risk compared to term babies of developing chronic kidney disease. Even those born late preterm, so less than 37 weeks, had an almost 2 times risk of term babies of developing chronic kidney disease. And what was interesting to me is that even those babies born at 37 to 38 weeks did have a slightly increased risk, so 1.3 times risk compared to those born greater than 38 weeks. Next slide. So this again was from the same study, looking at those 4 million people. And what I just wanted to highlight here is, so looking at this graph, along the x-axis we have age in years, and along the y-axis is your adjusted risk for developing CKD, so your times risk compared to someone born at term. And what I was kind of astounded by in this study is if you look at that first 15 years, those children, so up to 15 years of age, looking at the purple line and the yellow line, so the purple line being those born extremely preterm and the yellow line being those born late preterm, those infants have, 5-6 times the risk of chronic kidney disease developing in childhood. So not later when they're adults, but in childhood, which to me, that's just huge. That's such an increased risk for these kids. Okay, next slide. Okay, so this study was, I guess, really one of the things that really sparked my interest and passion in this area. So this study was a study that was published by Hingarani and colleagues back in 2022. And so what they did was they looked at a cohort of children that were born less than 28 weeks. They followed them up at 2 years of age. There were 832 children that they could have potentially followed up at 2 years, but only 565 of those 800 wanted to be involved in the study. So they got 565 2-year-olds. At 2 years of age, over half of them had at least one abnormal kidney measure. And the 3 things that they looked at or measured in this study were blood pressure, BP, albuminuria, which is protein in the urine, and we know that protein in the urine is bad and can cause kidney damage in the future, and protein in the urine is a sign of kidney damage. And the other thing they looked at was the kidney's filtering function. So this thing here, EGFR, is your glomerular filtration rate. Remember those little filtering balls we talked about? So GFR stands for your filtering rate and your kind of kidney function as measured on blood tests. And less than 90 is defined as chronic kidney disease. So to me, it's astounding. So 25% of these 2-year-olds had elevated blood pressure, 27% had protein in their urine, and already over 10% of them had reduced kidney function. And the other thing that kind of blew me away with this study is that they didn't actually manage to measure all three things on all 500 children. So it's most likely that these numbers here are actually an underrepresentation. Next slide. They looked at the factors, near birth or during your NICU stay that were associated with some of these bad kidney outcomes. And with regards to high blood pressure on the left, being of male sex, being African American, having a severe acute kidney injury, or indomethacin use during your NICU stay was more likely to be associated with high blood pressure. Having protein in the urine was more likely to be associated with being African American. Having a low kidney filtering function was likely to be associated with being born low birth weight, having a shorter birth length, maternal preeclampsia, or needing medications to support your blood pressure. So this was a different study done in teenagers who were born with low birth weight. So not looking at prematurity, but more by birth weight. And you can see here, so here is those born with a normal birth weight. In the middle is those born low birth weight, and on the right is those born very low birth weight. So again, we looked at the first thing, albuminuria or protein in the urine. There wasn't a difference across the groups, but looking at elevated blood pressure or low kidney filtering represented by the GFR, you can see that as your birth weight reduces, your risk of these poor outcomes increases. Next slide. So from this study, what they showed was that for every 13 children born with low birth weight, there was one child with high blood pressure and one with reduced glomerular filtration rate or kidney function. Next slide. One thing that I wanted to show from this study is they then broke it down by birth weight. So if you look all the way to the left, if your birth weight was less than 1,000 grams, your kidney function or having reduced kidney function occurred in over 50% of adolescents with a birth weight less than 1,000 grams. So already by teenage years, over half of these kids have reduced kidney function. Next slide. So what I just wanted to highlight here is if you go down, this is a table from that study. If you focus on the last part of the table, PIR less than 1. So what the PIR is the poverty ratio of the family income to poverty. So if you have a PIR less than 1, that means that your family is living below the poverty line in terms of income. And what you can see here is that with reducing birth weight, you have an increasing proportion of patients born or increased proportion of patients that are living below the poverty line. And so what this study shows is that if you're living below the poverty line, you're more likely to be born low birth weight. And then in addition to that, if you're born low birth weight, you're more likely to have chronic kidney disease. So this shows us that really we need to be looking at the social determinants of health to be targeting and preventing chronic kidney disease. Next slide. So what should we be doing about this? Next slide. So really a lot of the focus for monitoring recommendations for babies graduating from the NICU has been on neurodevelopmental outcomes. However, in recent years, as I've showed you with these papers, there has been increased recognition of adverse kidney outcomes. But despite this, there's still been little guidance on who we should monitor and how to monitor them. So two of the big two big pediatric societies, the Canadian Pediatric Society and the American Academy of Pediatrics, don't have any guidelines published on this topic. Next. But thankfully, there was a paper that does give us some guidance. So this paper was published in 2017 in the Lancet, and I think they do give some nice, clear recommendations. Next slide. So we'll just talk through this table. So there's in the two blue columns are the kind of, I guess, two main groups of how you would follow up infants. And then the green is any kind of risk factors that you might need to consider. So firstly, looking at that first column, if you're born less than 37 weeks or low birth weight or IUGR, or your mum has preeclampsia or gestational diabetes, it is recommended that at 3 years of age, you should start screening. You should screen yearly and you should have a blood pressure done and a urinalysis. And a urinalysis checked for that protein that we were talking about before. Then if you move to the middle column, the second one, if you're born less than 32 weeks or very low birth weight, or you have acute kidney injury as a neonate, screening should start before 1 year of age, should happen every year, and again, a blood pressure and urine check. So the screening is mostly the same, but with those born younger or smaller, the screening should start sooner. They also recommended that if you have other risk factors during your NICU course, like cardiac disease, a known kidney anomaly, if you're overweight at follow-up, or if you had neonatal kidney injury, you should, in addition to that, every second year, you should have a blood test for a creatinine, which is one of the markers that we use to calculate filtration rate, and then have your filtration rate calculated. They don't specify when you should start doing the blood tests, but I would be in favor of starting when the screening starts. Next slide. They then talk about what you should do in adulthood. So from the age of 18 to 40 years, you should have a blood pressure, have your body mass index measured, and a UA or urinalysis done every second year. But once you hit 40, those things should be done yearly. It's also really important to be educating families and patients about the importance of a low salt diet, a low saturated fat diet, physical activity, maintaining a healthy weight, and avoiding medications that could injure your kidneys, because all of doing those things can help protect your kidney health for lifelong. It's also important that adults who were born preterm or low birth weight shouldn't be living kidney donors, because then they would have increased risk of running into reduced kidney function in the future. Next slide. They recommend doing a baseline kidney ultrasound where possible to detect any abnormalities. However, I actually don't think that this is feasible, because then we would be having to do an ultrasound on almost every baby in the NICU. So my recommendation would be to do an ultrasound for those high-risk infants only, so those with cardiac disease, born extremely premature, and those with neonatal acute kidney injury. One other thing, it's really important to communicate any acute kidney injury episodes on the NICU discharge summary, so that providers looking after infants in the future can be aware of that increased risk. Next slide. I'd just like to point you towards some further resources. So the Neonatal Kidney Collaborative is a group of medical professionals who are interested in neonatal kidney health. You can go to their website, which I love the name, www.babykidney.org. There's lots of resources and recorded presentations there that you can seek. So next slide. In summary, preterm birth and low birth weight, I hope I've shown you, do significantly increase the risk of kidney disease in childhood, and studies have shown that we can see this risk as early as 2 years of age. We should be monitoring those who are less than 37 weeks or low birth weight every year with a blood pressure and urinalysis from 3 years of age, those less than 32 weeks or very low birth weight with an annual blood pressure and urinalysis from 1 year of age. And if you have other risk factors, you should have a blood test to check that creatinine and calculate the glomerular filtration rate every 2 years. And really importantly, educating patients about a low salt diet, healthy lifestyle, avoiding obesity, and avoiding medications that may harm the kidney. Next slide. So with that, I would like to say thank you for your interest in looking after little kidneys, and I'm more than happy to answer any questions you may have.
Dr. Sander, thank you so much for your presentation. It was very enlightening. I'm sure many people appreciate. We have a comment here for one of our viewers. Let me bring it here. Elizabeth says this is very helpful, coming from a mom with 3 preemies and 1 with very low birth weight baby. So, and I have to echo her words, because my preemie was born 900 grams. He's 11 years old now. Oh, wow. And we never ever checked for kidneys or any anomalies in his kidneys to this day. And so I'm very grateful that we really shine a light for all of us parents, and many healthcare providers are watching us from around the world. You can see on the chat later. So my first question to you is, how does a kidney injury looks like in the NICU?
Yeah, so the tricky thing with kidneys is you may not see kidney injury. So firstly, the way it's usually detected is via blood test. So that creatinine that I talked about, that is a measure of it. It helps measure your filtration of the kidney because it's excreted solely by the kidneys. So one way that it could be detected is that if your creatinine goes up on the blood tests, that would signal a kidney injury. And another definition of kidney injury is having reduced urine output, kind of reduced by a certain amount over a certain period. So those would be the two factors that define a kidney injury. Other things you might see though is that when the kidneys aren't working so well, and they're not able to excrete fluid from your body, you may see that a baby may become more puffy or gain a lot of weight very quickly. And other things you may see on the blood tests is electrolyte problems like sodium and potassium issues because the kidney is not able to handle that really well. But I think what is really challenging is that some of the more mild cases of kidney injury, you won't necessarily see or detect unless you're actually really looking for it. So unless a baby's having blood tests with a creatinine tested every few days, you may also miss it.
Okay, so Elizabeth asked a question, but I guess you already answered that question. Are there any early signs of symptoms prior to the ones mentioned, like decreased urine output or difficulty in weight gain? I think one of the things that we do in the ICU very often is weight to the diaper, right? I think all the parents here, like when we come home, do we still have to keep waiting the diaper? But I think I let you talk about that too.
Yeah, no, so I think that's really useful. I think you know, parents or nurses could be frustrated with having to weigh diapers all the time, but as a kidney specialist, I can tell you it is incredibly useful for us having urine output amounts. If someone does have a kidney injury and we come in to see them, having known what their urine output was from the previous days is incredibly helpful for us. So as much as it can be a little bit burdensome, it is really useful information.
So for the follow-up, because you mentioned there was no guidelines from CPS or for the American Pediatric Society, and at least in my case, I never even remember the kidney exists in the NICU. I don't think you had any issues in the NICU with kidneys. But I came home out of the NICU, we started seeing our pediatrician in the community. Kidneys were never, ever mentioned. Should we mention and request some tests to make sure everything is functioning well? Now, especially like my case, you moving into adolescence, as you mentioned, you showed the study, but or for the parents who are younger parents with younger babies at home, if we had no episodes in the ICU, should we still request tests for our babies?
Yeah, look, I think these studies that are coming out in the past few years really do warrant these things being done for infants, particularly those who are born extremely premature, so kind of, less than 30 weeks, less than 28 weeks, and born very low birth weight, so, less than 1,500 grams. I think the studies have shown that really the risk of kidney disease is high, unfortunately, in those patients. So it definitely does not hurt to speak up and say, look, I have this knowledge that, premature babies are at increased risk for kidney issues, and I want to just check to make sure everything's okay. The things that you would do would be things that they could do in the office with the pediatrician. So a blood pressure, every pediatrician should be able to check a blood pressure. It just takes a couple of minutes. Can be hard in toddlers who don't want to cooperate, but definitely that is one really easy, non-invasive thing to do. And same with a urine test. So once you're able to catch a urine. So if it's a toddler who can't pee when you kind of want them to, putting some cotton balls in the diaper to catch a urine to check for protein, that would be another test that you would do. And then the other thing that is a little bit more invasive would be a blood test. And you would ask to do a creatinine and calculated GFR on that. One study that I didn't have time to talk through today showed the importance actually of not just measuring the creatinine on the blood test, which most providers will do, but actually asking them to calculate that glomerular filtration rate. because this study showed that if you just measure the creatinine, it looks pretty similar to people who are healthy and well. But once you calculate that glomerular filtration rate, that's when you start to find the kind of subtle differences and changes in these kids' kidney function.
Okay, one thing that you mentioned, there was eye-opener, was moms who had preeclampsia. So this is something that I usually don't share with a pediatrician. Should these moms be advocating for their babies to be more proactive?
Yeah, so I think it's tricky because yes, it would be great for mums to be advocating for babies, but at the same time, I think, it's also the health professionals' responsibility to be kind of up to date with these things and being proactive about monitoring the health of these infants. And I also, it's tricky, I guess, because as pediatricians, when these kids are older, it's maybe not something that we focus on, the fact that mum had preeclampsia during the pregnancy. But we do know with preeclampsia, it can cause problems with kidney function, or blood pressure particularly is the main one in the future. So yeah, as well, if you're a mum who had a history of preeclampsia, definitely doesn't hurt to ask the pediatrician to check a blood pressure on your child or do a urine test.
Absolutely. So my last question to you is in terms of guidelines. Is there a movement happening in Canada, North America, to really push forward to have those guidance now that you have this guidance that was published on the Lancet? So where are we now here in North America on that?
Yeah, so I think one big part of that is the National Kidney Collaborative. So all these kind of health professionals coming together. And I think the tricky thing is publishing guidelines. You need to have a lot of evidence before you can kind of put a guideline together and say, yes, this is definitely what we recommend. And so while there are these studies that are coming out, I think it will take a little bit of time before the Canadian Pediatric Society and the American Academy of Pediatrics do put out a guideline saying, yes, this is definitely what we recommend. But definitely with the increasing amount of literature that is coming through and more evidence, I'm hoping it won't be too long until we see this.
That is wonderful. So I have one more comment here from Juliette. Juliette is joining us from the Netherlands. Thank you so much for your great and informative presentation. Being an adult preemie myself, born 28 weeks and 5 days in 1980, living with BPD, I focus on living a healthy, preventive lifestyle to lower the risk in getting more health issues. Being over 40, I ask my lung doctor to run yearly blood tests to monitor the biochemical function of my organs more often instead of waiting to get issues in health. And Juliette is a big advocate for the adults who are born preemie worldwide. And she always brings her voice as a big advocate for us. Do we need more adults to stand up and work together so we can have better outcomes in their health in the future for all the babies?
Yeah, most definitely. And that's great, Juliet. I think what I'm really passionate about is those preventative lifestyle measures, because they do make such a big difference. I look after kids who come in and are a bit overweight and have high blood pressure, and they lose weight and they're able to get off their blood pressure meds by eating less salt and being active. And so, yeah, really promoting those things among your family and patients, I think it can really go a long way.
It's wonderful. Dr. Sanderi, thank you so much for joining us here today. I'm very grateful that you took time away from your conference to really shine a light in our community, to educate us and to teach us how to be better advocates for our children. So thank you so much for being with us today.
No, you're very welcome. And if anyone wants to reach out and has any other questions for me, then I'm more than happy to answer any questions in the future. Thanks everyone for joining in.
You. Thank you. And to all of you watching us live today, thank you so much for being with us this afternoon. And a special thanks to our sponsor, AstraZeneca, who makes education sessions like this one possible. And just a reminder, if you missed part of today's session, head over to our website, which is the canadianpreemies.org, to see this episode and all past editions of Preemie Chats. You'll find many resources and support options available there. And you'll also be reminded that CPBF is a charitable organization and depends on support to continue its important work. please consider how you can support CPBF and its mission to empower families of premature babies every step of their journey. Together, we can create a brighter future for all preemies and their families. And we will see you again next week, next Friday, 1 p.m. Eastern Time. Stay well.